Okay, but next topic will cover approach to sphenoid sinus, pituitary surgery, hypophysectomy, and repair of CSF leaks in the sphenoid sinus. I'm actually from Penang, Malaysia. It's a beautiful island, yeah, where there's Cathay Pacific flies straight from Hong Kong to Penang. So guys, visit Penang Island one day. I first gave this lecture in Bern, in Switzerland. Bern is the capital of Switzerland. It means bear. And you walk along the streets, their rubbish bins are all the shape of bears like this. So I usually like to put this up to, and hopefully that all the things I'm going to tell you is not a lot of rubbish from the rubbish bin. Yeah. The surgical anatomy, the sphenoid is pneumatized very well, the cellular type in 86% of cases, precellular in 11% of cases, and concha in 3%. So there is no sphenoid sinus in about 3% of patients. So for approach to the pituitary, we don't consider approaching it through the sphenoid route in patients like this. Yeah. There's usually a central septum in the sphenoid, with about 76% of sphenoids having accessory septa, incomplete septa in the sphenoid. 1% of patients actually have absent septum within the sphenoid. The importance of the sphenoid septum is that it is often closely attached to the carotid artery. So in times when you have to enter into the sphenoid to do the pituitary work, the neurosurgeons want this septate to be removed. This septate must be cut and not avulsed. If you avulse it, you might avulse the carotid artery together with it. Yeah. When I was a trainee, I was taught we could do a sphenoid sinus washout, just like a maxillary sinus washout, blindly, by placing your trocar at the angle of 30 degrees to the nasal spine. You enter about 7 to 9 cm and you go into the sphenoid sinus. I'm glad that I didn't ever have to do this, because now we have endoscopes that can show us this. The sinus anatomy is about 2 cm in length, 1.5 cm in height, and about 1.5 cm in breadth. The important structures are the side, at the top, at the side. If you look at scans and you see the anterior clinoid process, you will know that on medial to the anterior clinoid process is the optic nerve. Yeah? And here would be the pituitary gland. On the lateral aspect would be the cavernous sinus containing the carotid artery and the various cranial nerves. MRI shows very clear pictures. Here you can see the optic chiasma, the pituitary stalk, the pituitary gland, and also the signal void of the carotid artery. All the structures, important structures on the lateral aspect of the sphenoid sinus, the optic nerve is here with the carotid artery. Yeah? Sometimes you can see the fifth nerve as an indentation in the lateral wall of the sphenoid sinus. The lateral bulges are visible in 71% of cases in the sphenoid, with bony dehiscence in the lateral wall, about 25% for internal carotid artery, and about 6% for the optic nerve. Here's a patient in the clinic. He has had a sphenoidotomy done through which we did a hypophysectomy. You can see here's the pneumatization of the anterior clinoid process. Okay. We can see that this is the optic nerve. As we go lower down, for some pulsation here, because this is a defect that is post-hypophysectomy. The carotid artery goes down here. In this particular case, you might just be able to make out the median nerve along the floor of the sphenoid sinus. Okay. The approaches to sphenoid include one, transethmoid, the one that we are very used to, because we do an ethmoidectomy, and after which we enter into the sphenoid. Yeah. We can do a transnasal approach. You can do a transseptal. Transseptal is something which neurosurgeons like to use for the pituitary, because they keep you in the midline. And in very rare cases where there is a problem in the lateral wall of the sphenoid sinus which you don't want to go to, you might have to do a transmaxillary approach. Yeah? The transethmoid approach on the left hand side, one has to go, this is the optic nerve. Optic nerve is here. So this one has an node cell. Yeah? Okay. And as you approach, one has to go on the like punching below the belt. You must go low, you must go medial and inferior. to get to the sphenoid sinus. So this is a transethmoid approach which most of us will do in our class. So we have gone through this. Now, this is a transseptal approach. It's useful, especially for trying to stay in the center of the sphenoid. Yeah? So Killian's incision, lift off the mucosal flaps. This approach will require the use of a speculum. Yeah? The anterior wall of the sphenoid sinus can be removed, and then we can work on the central aspect, yeah, of the sphenoid sinus. Here's a patient who has got an isolated sphenoid sinus abscess, and the best method here would be a transnasal approach. Here's a patient with a pus on the right hand side. Yeah. So it's important to decongest this area with patties, with adrenaline, and go on to the face of the sphenoid. This is the nasal septum. So it's very safe to go into this area. So here is where we get the pus. Yeah. And the debrider to open up the area. It's very safe to move on to the posterior septum medially. Take away part of the anterior wall along the floor. Okay, and this exposes the sphenoid sinus. Yeah. Okay. Here's a patient who had various approaches of sphenoid. Yeah. He's got both a transnasal through here. This is the middle turbinate, what is left of it. Yeah. He's got a transethmoid approach, and he had also a transmaxillary approach. The reason why we had to do this was because he had a big, it's a lot of inspissated mucus within this sphenoid that had to be removed. Yeah. So here's a view here through a transnasal approach. The central septum of the sphenoid has been broken through, and this is the other side of the sphenoid, which is a smaller sphenoid cell. So this is the other sphenoid, and the other side. And here you can see that the cilia of the sphenoid causing the glistening of the light, the movement of the light. When I was in Pittsburgh giving this lecture, I told them the famous story that Professor Steinberger always tells during his courses, how there's only one time in history where smoking was beneficial to men. The reason is Professor Steinberger's predecessor used to dissect fresh cadaver heads. So when in a fresh cadaver head, you have cilia still moving. So he was a heavy smoker, and so some of the ash, okay, sorry, this is a transmaxillary route. Some of the ash from the cigarette fell onto the fresh cadaver heads. And after a while, as he turned and looked at the fresh cadaver heads, he found that all the ash was moving towards a natural sinus ostia. And that's how functional endoscopic sinus surgery was born. Yeah? That all the ciliary action goes towards the natural ostium. Yeah? Now, in the case where patients with a transmaxillary route, if you require more space to work here, one can remove this part of the maxilla and get ready to cauterize the sphenopalatine artery. Some cases in traumatic problems for the facial, where there's facial injury and trauma to the orbital plate, there may be impingement of the orbital plate into the orbit, and one has to then decompress the optic nerve, as you have seen in the demonstration yesterday. It's important to know that the ophthalmic artery causes medially in 16% of cases. So as you cut the orbital periosteum, it's important to avoid cutting the ophthalmic artery. Otherwise, the patient will be just as equally blind. Yeah? Here's a patient with a sphenoid mucocele. He had nasopharyngeal cancer, post-radiotherapy. All the cilia are not working, yeah, in the sphenoid. So this develops and causes him to have a big headache. Yeah? And in fact, there is already erosion of the posterior wall of the sphenoid. So all this debris was removed, and that is why we had that picture of a transnasal, transethmoid, and a transmaxillary approach. Yeah. There was exposed dura at the end of the operation, but this is not in any way a problem, because as long as there's no CSF leak, this dura does not cause any meningitis, this exposure of dura. Here's a patient with a bit of a sphenoid mucocele, but he also had a bit of fibrous dysplasia. So she developed early signs of like cavernous sinus thrombosis, and this sphenoid mucocele then required drainage. Yeah. So in this case, one had to go on a transnasal approach. We didn't have an image-guided system then, so we had just put a drill here and just kept pushing on until we see a big gush of stuff coming out. And it was a good thing that it was just the contents of the mucocele. This operation was made more difficult because this happens to be a wife of the chief neurosurgeon in our hospital, but she is well now. So here is the post-operative view where the mucocele has been removed. Yeah. Here's a patient with a head injury. You can see that there's a fracture in the frontal bone, massive fractures, and lots of CSF leak in this particular patient. The neurosurgeon had gone in and repaired the anterior cranial fossa, and he has followed the fracture line back until he reached the optic chiasma. Now he couldn't follow the fracture line anymore, and he suspected the fracture line may then go through the sphenoid, and that's why they called the ENT surgeon to help out. So in this particular case, I went through a transeptal route. This swelling here is a hematoma that has raised the mucosa of the sphenoid off the posterior wall, and this has been removed. This is the central septum here, the central septum. We were suspecting that the fracture line was coming down along the anterior cranial fossa and along the lateral wall of the sphenoid here. So here, after peeling off the mucosa, you can see that there might be a very small CSF leak here. Yeah? In cases like this, repair is fairly easy. Yeah? We do not want to open up more bone to look for the leak. Yeah? Tissue glue is placed. Yeah? Some fascia is placed on top of it. Fat is then placed into the sphenoid. Yeah? Okay, so fascia. Okay, here's a patient who got into a problem after having a big sneeze. He had upper respiratory tract infection. He was sneezing and blowing his nose away, and then suddenly he had a lot of water coming out from the nose. He later developed headache and neck stiffness, so he developed meningitis. Radiologists had done scans with contrast for him and indicated that there may be a leak on the lateral aspect of the sphenoid sinus. So here you can see the leak coming on this area. Yeah. Now, because he had a problem, he had bilateral sinusitis, we elected to go in by a transeptal route. But that is actually not the ideal route, because you will it's very difficult to work on the lateral wall if you go on a transeptal route. After we went in and we looked on the lateral wall, there was no leak. Yeah, we couldn't find a leak. So with a 70-degree scope, we can see the carotid artery coming down. There was no leak, so we then had to have a look around. Yeah, all the CSF had by then all already come out. Yeah. We noticed, of course, that there was a bit of irregularity here. Looks like some small openings there. So the mucosa of the sphenoid sinus has to be removed to expose the leak. Yeah. So here we can see finally the CSF leak. Yeah. It's coming out from very small holes. This patient probably had some congenital dehiscence of the posterior wall of the sphenoid sinus, and with this big sneeze, he had a CSF leak. So this is easily repaired. There are small holes. Small holes can be repaired with just fat plugs. Yeah. So this fat plug was placed and the tissue glue was placed there, and more fat was put as a support. Yeah. I tried the PJ Wormo's fat plug technique, but was unsuccessful here because of the angle. So the leak, instead of being reported, as what was reported by radiologists, was not here on the lateral aspect, but was in the central aspect of the sphenoid. Here's a patient with a remnant chordoma with a CSF leak. This particular patient had a transcranial excision of a chordoma and later developed a leak coming out from the sphenoid. I have opened up the sphenoid here, the anterior wall, taken down the septum, and this is where the leak is, and this is where the remnant chordoma is. This patient was scheduled to go for radiotherapy and required that this leak to be repaired. Same thing, because it is a very small leak, it always seals easily with an onlay technique. Yeah? So mucosa is placed here, tissue glue and fat on it. Yeah? So. Okay. So in selecting an approach for sphenoid sinus pathology, it depends, one, if this patient has already posterior ethmoid disease, like in most of the cases that we see, and then there is a sphenoid sinusitis, then we go by the transethmoid route. If it were an isolated sphenoid disease, if there was a previous ethmoidectomy, we can go through a transethmoid route. If there was no previous ethmoidectomy, it depends on the location. If it's something that you want to stay in the center, like the pituitary, then we go transseptal. If it's paramedian, like for example, one sphenoid sinus is involved, we go by transnasal, like the sphenoid abscess you saw. If it's lateral, very lateral, you can go through a transethmoid route. And if it's extremely lateral, you may have to do a transmaxillary route, where you must be ready to take the sphenopalatine artery. Yeah? Now, something on pituitary tumors. The reason why we can do pituitary tumors through the nose is because the arachnoid mater does not descend with the dural mater into the sphenoid. Yeah? So as we do a hypophysectomy, we're only dealing with the dural mater. If we were to remove a lot of the bone on the anterior aspect to expose the tumor, sometimes you can hit this area and cause a CSF leak. It's more troublesome. Yeah? How you approach a pituitary tumor depends on how you train the neurosurgeon. See, a neurosurgeon is trained to go by a transseptal sphenoidal route because this is dead center, and they are very confident with this route. ENTs have described transethmoid route, transnasal route, and in Singapore we are doing a transnasal route but a bilateral approach, because we find that using a transnasal route, if you're only holding an endoscope with one hand, you have only one other hand to use, whereas now we are taking down both the anterior walls of the sphenoid sinus on both sides, put an endoscope on one side, and on the other side you can use a suction instrument and your forceps to handle the tumor. So in the transethmoid route, the ENT surgeon can stand on one side and the neurosurgeon stand on the other side. Here's a typical case, a patient with a pituitary adenoma, and here you can see the optic nerve up here. This is the central septum that's been cut away, yeah? And this is where the pituitary fossa is. Yeah? So the neurosurgeons have very fine rongers that they can use to remove the anterior wall of the sphenoid, so the posterior wall of the sphenoid. And this is where you remove the pituitary adenoma, send this for biopsy. There can sometimes be a venous ooze, and they can fill up the operative field, and you want to use a cautery. So if you have two hands, then you can use a suction and a cautery at the same time, yeah? From one side of the nose. The endoscope is now on the left side of the nose, and the neurosurgeon is on the right side of the nose. Okay. After removing the tumor, the sella drops down. This is the arachnoid mater. Yeah, and we do not want to go through the arachnoid mater, because if you go through that, then you get a CSF leak. Yeah. Okay. This is the arachnoid mater. Yeah. So with two hands, the neurosurgeon can push the arachnoid mater down, and you can see there's some more tumor there that can be removed. Yeah. So you couldn't possibly do this if you only had one hand holding the endoscope and one other hand for an instrument. And if there is no CSF leak from the operation, then packing is very easy. Yeah? We don't have to try to pack to stop CSF leaks. Okay, usually we place some fat into the area, and if the patient comes out, it's as if he had just had a nose operation and not a brain operation, and not an intracranial operation. Now, so it looks quite simple enough, but before we rush in to do this operation, let me tell you the complications that I've heard of or know of. Well, one of the things is, as I mentioned earlier, to avoid any CSF leaks, you should keep the opening small and not to take bone on the anterior aspect, because this is where the arachnoid mater is adherent to the dural mater, and it can cause a CSF leak. The complications I know of are two cases, one reported in another hospital, one in my hospital, where about 10 hours after operation, the house officer calls up and says the patient is going blind. Usually it's because of a post-operative hematoma. Treatment is to remove the PECs, and the patient will recover. Yeah. We know of one case where after the patient had surgery, he developed massive bleeding about 4 days after the surgery. Yeah. He had developed a pseudoaneurysm of the carotid artery. And you can see this is a beautiful picture of bleeding from the carotid artery, done on Adobe Photoshop, of course. In this particular case, where you have bleeding from the internal carotid artery, it is not a surgical procedure going to the neck to ligate the vessel, but your best friend is still your interventional radiologist who will block off the vessels. Yeah. In this particular patient who had a very cystic mass, after removal, the patient could not be aroused from anesthesia, and what she had was an intracranial hemorrhage into the brainstem, and both pupils became pinpoint. Yeah, so it is not something you want to do by yourself. You must always do it with your neurosurgical colleague. Andrew, are we time?